graduate blocks are imaging and therapy. We have a GitHub page for this, but typically
Good morning, Dr. Anam.
Good morning, Alhamdulillah. How are you?
Fine, thank you.
Ya, Alhamdulillah. Ya, Prof. Hidawati, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Sehat ya, Prof?
Alhamdulillah sehat. Ini suaranya jelas ya, Pak Anam?
Oke, jelas, Prof.
Oh, ini Pak Panji juga sudah hadir.
Oke.
Sehat ya, Pak Panji.
Alhamdulillah, Prof. Sehat, alhamdulillah.
Nanti kita mulai jam 8 tepat nih, Prof.
Yeah.
Nanti saya izin sebentar. Assalamualaikum.
Waalaikumsalam warahmatullahi.
Ya,
Oke.
Prof. Widowati, Prof. Henry.
Ya.
Ya, dari IPPT kita ada Associate Pro Dr. Hasni.
Ya. Assalamualaikum, Profesor Hasni.
Waalaikumsalam warahmatullahi wabarakatuh.
Assalamualaikum, Prof. Hasni, Prof. Widowati, Dr. Murdiana, Pak Anam,
Waalaikumsalam
dan Bapak Ibu
warahmatullahi
semua.
Waalaikumsalam warahmatullahi wabarakatuh.
Mohon maaf saya pakai rompi ini untuk mengenalkan Napismi nih Indonesia gitu nih. Kemarin dikirimi Pak Anam ini. Oh, yang ini deh. Oke. Baik. Cek Pak Panji untuk narasumber udah hadir.
Siap.
Alhamdulillah ini belum on kamera jadi belum kelihatan.
Menunggu virtual background dari Pak Anam.
Oh iya, ini sedang OTP. Ya.
Oh, ada VB-nya ya.
Assalamualaikum Prof. Jarwani. Semoga sehat selalu, Prof.
Waalaikumsalam warahmatullahi wabarakatuh.
Sehat, Prof.
Alhamdulillah sehat walafiat.
Baik, Rob.
Dengan juga ya.
Nggih. Jakarta aman terkendali ya, Rob.
Aman terkendali. Sudah mulai panas sekarang.
Nggih. Semarang masih sejuk, Rob. Alhamdulillah.
Ya.
Iya. Ini Pak Kipir sudah siap sebagai moderator, nggih.
Nggih.
Pak Kipir ini beliau jarang on cam kalau nggak jadi moderator, Rob.
Tapi kita memang harus memberikan ini loh, memberikan atensi khusus loh untuk kardiak ini. Karena untuk kateterisasi jantung itu di tanah air itu sekarang sudah ada 400 center lebih.
Ya, Prof ya. Cukup banyak ya.
More than that.
Iya.
Saya memulai itu memulai mempelajari sedikit-sedikit ya kan, itu mulai tahun berapa Mas Anam tahu ya Mas Anam ya? Itu waktu itu tuh baru ada senternya itu baru mungkin ada 10-an gitu. Sekarang tahu-tahu beludak 400 loh. Dalam waktu itu 10 tahun.
Iya.
Assalamualaikum, Prof. Darwani.
Waalaikumsalam warahmatullahi wabarakatuh.
Widowati, Prof.
Oh, siapa? Megawati.
Bu Dekan, Prof.
Mantan Presiden
Ayo.
Megawati.
Dekan.
Widowati Bu Wido.
Iya.
Saya matur nuwun loh dapatkan kesempatan ikut.
Kita sudah lama nggak jumpa, Prof.
Iya, saya itu sekarang semenjak COVID itu saya sudah tidak pergi-pergi. Jadi kalau misalkan sekarang disuruh naik plane gitu, mungkin sudah deg-degan mungkin dia. Naik kereta juga sudah enggak. Jadi saya 4 lebih dari hampir 4 tahun ya saya tidak keluar-keluar. Jadi ke Semarang juga sudah enggak.
Jarang. Ya kapan-kapan. Kan sekarang sudah lumayan kondusif suasananya.
Iya, tapi katanya ini meningkat lagi ya? Enggak ya?
Nggak tahu ini. Berarti fluktuatif ya.
Iya. COVID ini benar-benar ya mengubah lifestyle bener deh. Tidak hanya di kita tapi seluruh dunia juga. Tapi kalau seandainya nggak ada COVID, mungkin ya pertemuan begini-begini juga nggak marak ya.
Betul.
Ya, ini virtual background-nya sudah di-share di
Room chat.
di room chat ya. Mungkin barangkali bisa di-download. Terima kasih. Nah, ini Pak Panji sudah pakai mikrofon pesawat.
Siap, pakai batik baru, Prof.
Oh iya, batik baru. Sebentar lagi ada jasket baru, Pak Panji, sabar. Habis lebaran, insya Allah.
Alhamdulillah. Prof Jarwani, apa kabar, Prof? Assalamualaikum.
Baik-baik, alhamdulillah.
Lama nggak
pula Pak Panji nggih.
Maaf, lama nggak ke Depok ini.
Iya.
Insya Allah kapan-kapan mainlah sama Pak Anam nanti.
Ya, wah saya senang sekali. Tapi saya juga sudah nggak ke Depok loh. Nanti kalau misalkan ke Jakarta ke rumah aja ya.
Oh siap. Saya ini Prof nanti bakal sering ke LSPAD nanti ambil data.
Sudah dimulai nggih?
Nggih, monggo.
Pak Anam.
First, IPPT USM Undip join webinar on multimodality
cardiac imaging. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Respectable the Dean of Faculty of Sciences and Mathematics, Diponegoro University, Professor Dr. Widowati SSI MSI, Honorable Deputy Director of Research and Networking, Institut Perubatan dan Pergigian Termaju, IPPT, University Science Malaysia, Profesor Madya Dr. Hasni bin Arsyad. Honorable, the Head of Physics Department, Diponegoro University, Professor Heri Sutanto. Honorable, invited guests, participant, and committee, IPPT, USM, Undip, joint webinar. Welcome to the first USM, Undip, joint webinar on multimodality cardiac imaging, 15th April 2023. With our speakers, first, Dr. Hadijah Abdul Hamid from University Sciences Malaysia. Overview of SPEC cardiac imaging in nuclear medicine. And the second, Dr. Panji Triadiaksa from Diponegoro University with the topic magnetic resonance evaluation of myocardial iron loading. And the third, Dr. Nur Hairiyah A. Karim from University Sciences Malaysia with the topic role of cardiac computed tomography, CCT, and cardiac magnetic resonance imaging, CMR, in diagnostic cardiovascular disease. First of all, let us praise to the Almighty Allah Subhanahu wa Ta'ala. Because of His blessing, we can attend in this event. Secondly, may peace be upon the Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness era to the brightest era. Ladies and gentlemen, my name is Mira Anjani, as the Master of Ceremony in this morning. And let me read out our agenda. The first, opening. And the second, speeches. The third, we have photo session. And the fourth, we have main webinar session. And the last is closing. The first agenda is opening. Let's open this event by reading Tasmiyah together. Bismillahirrahmanirrahim. Hopefully, with reading earlier, this event can run smoothly as it should. Ladies and gentlemen, step on to following. The agenda is speeches. The first welcoming speech will be delivered by the Dean of Faculty of Sciences and Mathematics, Diponegoro University. Dear Professor Dr. Widowati SSI MSI, time is yours.
Thank you very much, Master of Ceremony, Mira Anjani. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Your Excellencies, Profesor Madya Dr. Hasni bin Arsyad, from Timbalan Pengarah Penyelidikan dan Jaringan, or Deputy Director of Research and Networking, Institut Perubatan dan Pergigian Termaju, or Advanced Medical and Dental Institute, University Science Malaysia. Honorable Professor Dr. Heri Sutanto, as a Head Physics Department, Faculty of Sciences and Mathematics, Diponegoro University. Honorable Professor Dr. Jarwani, and also honorable speakers from University Sains Malaysia and Diponegoro University, Dr. Hadijah Abdul Hamid, Dr. Nur Hairiah Karim, Dr. Panji Triadaksha. All lecturers, researchers, and students from Physics Department, and also from other faculty, such as from Faculty of Medicine, Diponegoro University. All lecturers, researchers, and students from University Sains Malaysia. All respected participants of the first joint webinar IPPT University Sains Malaysia and Diponegoro University. According to information for the committee, this webinar is mainly attended by students, lecturers, and researchers from University Sains Malaysia and Diponegoro University. This joint webinar is also attended by students, lecturers, and researchers from several universities in Indonesia and Malaysia. Also, it is participated by clinical medical visits from many hospitals in Indonesia and Malaysia. First of all, I would like to welcome all of you to the first IPPT University Sains Malaysia and Diponegoro University joint webinar. Thank you for being here with us today. I would also express my sincere appreciation to the organization of this event, both from Diponegoro University and University Sains Malaysia. This joint webinar is a follow-up to the visit of Physics Department staff to the IPPT USM in December 2022. The staff will visit IPPT USM with Professor Dr. Heri Sutanto, Dr. Khairul Anam, Dr. Eko Hidayanto, and also Yainal Arifin, MSc. Previously, one of the staff from IPPT USM had also given a public lecture on CT dosimetry in the middle of last year in Physics Department, namely Dr. Nur Diana Usma. Thank you very much for Dr. Nur Diana. I am very pleased that this joint seminar has finally come true for the first time. I hope that the cooperation with IPPT USM will be further enhanced. I hope that other activities will be initiated, such as joint research, joint publication, student mobility, or lecturer mobility between USM and Diponegoro University. I should be noted that Universitas Diponegoro has a world-class university staff exchange program, which allow funding for our staff to visit institutions abroad or professors from abroad to visit Diponegoro University. We realize that both institutions, Diponegoro University and University Sains Malaysia, have their own strengths and weaknesses. By strong collaboration between both institutions, the shortcoming of each can be covered by the others. I hope that in the future, the collaboration between Diponegoro University and University Sains Malaysia will be even stronger. I hope that through these events, we all can learn from experts from Diponegoro University and University Saint Malaysia. Once again, welcome to all of you and thank you very much for attending this event. I wish all participants will gain fruitful knowledge and experiences. Last but not least, by the grace of God Almighty and consent of all participants, on behalf of Faculty of Science and Mathematics, Diponegoro University, I am as a Dean hereby announce that first joint webinar between Institut Perobatan and Pergigian Termaju University Saint Malaysia with Diponegoro University with topics multimodality cardiac imaging is open. I encourage all participants to participate actively in the interesting discussions. At the end of this fasting month, I will say, Taqabbalallahu siyamana wa siyamakum, sholatana wa sholatakum, wa antum kula amin bi khorin. Minal aidin wal faizin, mohon maaf lahir dan batin. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you for the speech, Professor Dr. Widowati, SSI, MSc. The second speech will be delivered by the Deputy Director of Research and Networking, Institut Perubatan dan Pergigian Termaju, IPPT, University Science Malaysia, dear Professor Madya Dr. Hasni bin Alsad. Time is yours.
Okay. Assalamualaikum warahmatullahi wabarakatuh. Terima kasih.
Waalaikumsalam warahmatullahi
Thank you, Mrs. Chairperson for today, Mira Anjani. First of all, let's we salawat to Rasulullah sallallahu alaihi wasallam. Bismillahirrahmanirrahim. Allahumma salli ala sayyidina Muhammad qulubi wa dawaiha wa afiyatil abdani wa shifaiha wa nuril absari wa dhiyaiha wa ala alihi wa sahbihi wa barik wa sallim. Alhamdulillah, shukrillah, because of today we have a plan for the first seminar, and then we are today successfully to have a joint webinar between IPPT, Advanced Medical and Dental Institute, and also UNIDAP, University Diponegoro, Indonesia. First of all, I would like to congratulate to all of the secretariat who are giving a full commitment to make sure that this a seminar becoming a reality, because this is not a easy task for us to conduct this kind of seminar, because this is involving two big country between Indonesia and also Malaysia. And also on behalf of the management of Advanced Medical and Dental Institute, we are fully support this kind of collaboration, because of it's not easy to maintain of the collaboration, because of normally once we do MOU or MOA, Memorandum of Understanding, Memorandum of Association, normally they are ending with nothing. Okay, this is a very good starting between IPPT and also UNIDIP, because of it live, meaning that the collaboration is live, okay, between two institutions. And also and see that the person in charge here, Dr. Diana is very good, very highly committed with this collaboration, because she was mentioned that she been at University of Diponegoro, isn't it? Because he been there and also do some ground working over there. So this is a very good sign that this collaboration will be very long last. Okay, So this is very healthy collaboration between two countries. As you know that, because some of you have been at IPPT before, we are at IPPT is working toward translational research. What is a translational research? Translational research is the research that designed to make sure that what we did at the laboratory at IPPT or Advanced Medical and Dental Institute can be used by the community. Because what we did in here, we use community money, because so we need to make sure that what we did at IPPT or what we did in the university, it give back to the community. Okay, so at IPPT we have 5 type of the research niche area. For the first is imaging infection disease. So it's looking at the preparation for the disease act, because we have experience with COVID-19, so we may not prepare with the what is the next imaging infection disease. So we form a group that looking at the imaging infection disease preparation for the disease act. For the second niche area is advanced management of liver meningitis. So we look at the how to make sure that the liver cancer patient has suitable management or suitable drug for them. The third one is as we know that we are aging, so we prepare one of the research program looking at the dementia as a multidisciplinary research program of IPPT. So they look at the dementia kind of research. So the fourth one is breast cancer translational research. So as we know that the majority of the cancer occurred in Malaysia is related to the breast cancer. So that's why we are also focusing on the translational research in breast cancer. The fifth one is the heart failure research. So it's look at the any angle related to the heart failure. So I hope that this collaboration can have a platform that give in and take between the two institutions. So that is the idea or the vision of the this kind of collaboration. So I'm also thanks to the Professor Dr. Widowati, Dean of Faculty of Science of Mathematics, and also Professor Dr. Heri Sutanto, head of the Physics Department. This is very we need your support to make sure that we also can contribute to the people. So what we have here, inshallah, we will share with you all in over there. So I understand that we also here has a advanced kind of facility. It's not that advanced actually, but we can share what we have in IPPT. Within 2 years, I'm also plan to have one unit cyclotron, which is can provide for the provide what we call radionuclide that we can use for the patient. Okay, so also we can share that facility for the research purposes. So inshallah, I hope that this committee will have more collaboration in terms of the, for example, we need the output in the collaboration. For example, if we have collaboration, we should as a research group. So I hope that there are at least one research group was grow from this collaboration. The second one, if we are scientists, of course, we need to have a grant, for example. So maybe there are some grant from IPPT and also a grant from the University of Diponegoro. And also, I hope that this collaboration produce a manuscript or in journal publication. So we share in the journal publication, for example, and also we should have the exchange of the students. So student over there can come here and student from here to be there. So they have the real experience between two different environments. So this will give a very good impact to the student. And also maybe we have a kind of the community kind of collaboration. Maybe the people from University of Diponegoro meet the people in here what they need for to be focused in research. And also we are from here, the student and the lecturer from here to be there and also look at and meet the people over there and understand what actually they need from there. I think between that two live communication, we can get very good experience and also very good in terms of the collaboration. I think that's all from me, and also congratulations to the committee because making this collaboration and also this joint webinar become a reality. I think that's all from me. Sekian. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
wabarakatuh.
That is the speech delivered by Professor Madya Dr. Hasni bin Alsat. We thank you. Our third agenda is photo session. There is 9 screens in the section, so we need to take the picture for some minutes. Please, ladies and gentlemen, turn on your camera. Get ready for the first screen. 1, 2, 3. Okay, the second screen. 1, 2, 3. Okay, get the best pose. 1, 2, 3. The fourth screen. 1, 2, and 3.
Yeah. Okay.
The fifth screen. Once more. 1, 2, 3. And the next 1, 2, 3. Okay, 7. 1, 2, 3. Okay. The last once more. 1, 2, 3. Okay, thank you. So, ladies and gentlemen, the next agenda is our main session of webinar. We have some speakers. Our 3 speakers, the first is Dr. Hadijah Abdul Hamid from University Sciences of Malaysia with the topic, Overview of SPEC Cardiac Imaging in Nuclear Medicine. And the second, Dr. Panji Triadiaksa from Diponegoro University with the topic, Magnetic Resonance Evaluation of Myocardial Iron Loading. And the last, Dr. Nur Hairiyah Al-Karim from University Sciences Malaysia with the topics, Role of Cardiac Computed Tomography and Cardiac Magnetic Resonance Imaging in Diagnostic Cardiovascular Disease. This agenda is about 2 hours with our moderator, Dr. Kidir Maulana Binu Susanto, the staff of Physics Department, Diponegoro University. Dear Dr. Kidir Binu Susanto, are you with me?
Yes, I'm here.
Yes. Okay, Dr. Kidir Maulana Binu Susanto, time is yours.
Okay, thank you, Mbak Mira Anjani. Okay, as mentioned by Mbak Mira Anjani, my name is Kidir Maulana, and I will serving you as moderator today in this joint webinar. As told by Mbak Mira, we will have 3 speakers. The first one is Ibu Dr. Khadijah Abdul Hamid with topics Overview of SPEC Cardiac Imaging in Nuclear Medicine. And the second one is Bapak Panji Triadiaksa with topics Magnetic Resonance Evaluation of Myocardial Iron Loading. And the last one is Ibu Dr. Nur Hairiyah Al-Karim with topics Role of Cardiac Computed Tomography and cardiac magnetic resonance imaging in diagnosing cardiovascular disease. Okay, and because we only have 2 hours, so theoretically, each speaker only have total 40 minutes. And let's say we have 30 minutes for presentation and 10 minutes for discussion. Okay, and if the audience have a question in the middle of talk, please write the question in the chat room, and we will read it in the discussion session. Okay. Okay, and before we start the first session, let me read the curriculum vitae of the first speaker, Dr. Khadijah Abdul Hamid. Okay, Dr. Khadijah is a nuclear medicine specialist with bachelor degree in medicine from University of Sheffield in 2005. She received her Master of Medicine degree in nuclear medicine from University Science Malaysia in 2013. Her master's training was done at USM and the University Malaya Medicine Center in Kuala Lumpur. And she was awarded Fellow of Asian Nuclear Medicine Board status in 2017 in Yokohama, Japan. Advanced Medical and Dental Institute is the only university in Malaysia that has produced clinical nuclear medicine specialists since 2012, and Dr. Khadijah is the head of this master program for the year 2023. That's the short CV of Ibu Khadijah, Ibu Dr. Khadijah. And without further ado, Dr. Khadijah, the time is yours.
Okay, Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, sorry, I am not so good with Zoom. So, do you prefer we speak in English or bahasa?
I think bahasa Indonesia is okay if you're okay with that, because I think almost participant is from Indonesia.
All right. But the slide is in English. Okay.
Okay.
So today I will talk about the overview of cardiac imaging in nuclear medicine. The reason why I choose SPEC because at this moment, this is the only gamma camera that we have in our department. So as an introduction, cardiovascular disease is the leading cause of death in Asia in 2019, approximately about 10.8 million deaths, and about 1/3 of the total death in Asia. And about nearly 39% of these deaths are premature, which is defined as the deaths less than 70 years old. So this is the figure to show that the cardiac disease mortality rates in Asian countries by region. And I have highlighted Indonesia and Malaysia there. It shows that Indonesia is the second highest in Southeast Asia, and Malaysia is the 5th in Southeast Asia. So this is just to show that we can diagnose cardiovascular disease using various modalities. So we can use echo, CT scan, SPECT scan, PET scan. And for nuclear medicine, it belongs into the functional test. For radiology department, it's most of the time is anatomical test. Myocardial perfusion scan is a non-invasive evaluation of myocardial blood flow. We use radiopharmaceuticals such as TC99M Systamibi, TC99M tetrophosphine, and thallium-201. But for the thallium-201, we rarely use it now because of availability and some issues. And photon energy is 140 keV for technetium 99M. And of course, we use a gamma camera, but currently we have cardiac dedicated CZT camera, which is only do cardiac test, cardiac scan. We can do myocardial perfusion scan with 1 day or 2 day protocol. And positron emission tomography is also can be used for cardiac imaging, but we don't have it yet in IPPT. We might have this possibly in next year or next 2 years. So this is the principle of myocardial perfusion scans. What we scan is the myocardial blood flow during stress and rest, because there are difference of coronary blood flow during stress and rest if there is stenosis in the blood in the coronary arteries. So at rest, even there is stenosis, there will be no difference in the perfusion, cardiac perfusion during rest. But during maximum stress, there will be a difference in myocardial perfusion where the normal coronary arteries, the normal muscle will have the maximum cardiac supply, but the one that is already have stenosis, we can see there is much reduced blood supply there. So these are the principles of our myocardial perfusion imaging. For the indications, of course, for the detection of ischemia in symptomatic or selected asymptomatic patients, for examples, in a patient who have a screening and was found to have an abnormal or equivocal stress test, the exercise stress test. So we have that kind of patient to identify the area of culprit lesions involved, especially in cases of multivessel disease, pre-vascularization, assessment of viability of ischemia, post-revascularization, intervention evaluation, and also assessment of the hemodynamic significance of coronary artery, coronary stenosis or restenosis after coronary angiography or after PTCA is done. So these are absolute contraindications before we do the stress test. Obviously, we have to screen the patients for their blood pressure. If there is recent angina or currently they have angina symptom. Angina means if they have any chest pain during exercise, and some other contraindications that you can see here, and also relative contraindications. This is why it is important for the patients to be seen by the clinicians before we do the stress test. So how do we do the stress test? It can be done by 2 ways. One is exercise stress test, and the second one is a pharmacological stress test. The exercise stress test involve a treadmill, which is a standardized protocol. We use a Bruce or modified Bruce protocol. And the pharmacological stress test, we have many drugs then we can use to mimic the stress that is done in exercise stress test. So these 4 drugs are the most common used. So first I will talk about, I will talk about the dipridamol first. Okay, this dipridamol, or we call it percentin, is mostly used in Malaysia. This is indirectly increase adenosine in the blood by prevents intracellular reuptake of adenosine. So the half-life is about 30 to 60 minutes and can go up to 10 hours. The side effects are bronchospasms, headache, chest pain, soreness of breath, muscle cramps. So because of the half-life is so quite long, Some patients may have late symptoms or after the stress test, but we have drugs that we can reverse these symptoms. So how do we know if the patients really have a heart disease? I mean, if the symptoms is related to the heart disease or related to the drugs, is by looking at their ECG. Okay, during the stress test, we will do the ECG simultaneously. The second drugs is adenosine. Half-life is very short, about 2 to 10 seconds. It blocks A to B receptors. So because it's quite selective, the side effect is slightly less, and it doesn't need the reversal because because of the half-life is very short. And the third one is a regadenoson. This is the most recent drugs, and this drug is very good. It is a selective drugs to vasodilate, and these drugs can be used for the patients, for asthma patients. The two other drugs like pudendal and adenosine is contraindicated in asthmatic patients. So for asthmatic patient, we need to use dobutamine. This is a direct beta 1 and beta 2 stimulations to increase the heart rate, increase the blood pressure, and myocardial contractility. So, but half-life is 2 minutes. The onset of action is between 1 to 2 minutes, but the peak effect can go up to 10 minutes. So the problem with dobutamine is it's very slow in increasing heart rate. So we can use other drugs, atropine, to increase the heart rate if you want the study to be done faster. Okay, these are the summary of what I have said before. So what to expect during a nuclear stress test? So of course, first we will put the ECG lead at your chest, and we will ask you to walk and then run when the intensity increases. And near the maximum heart rate, radioactive tracer will be injected through an IV line. After that, we will ask the patient to rest depends on whether it's a stress. Okay, this is a stress, so we can go up to 45 minutes to 1 hour, ask the patient to rest, and after that we can scan the patient. And for rest, it's quite simple. When the patient comes, we take the blood pressure, all the vital signs, and we can straightly inject the radiopharmaceutical into the patients and then scan. This is the position of patients. When we do the scan, you can see this detector. This is the detector, SPECT detector. We position it in the left anterior oblique in the 90 degrees like this, because the heart is located there. So we want to move the gamma camera as close, the closest to the heart. So this is the position. So if the patient is a dextrocardia, so if the patient has the heart on the right, so obviously we have to move the detector to the right. Mechanism of localization of this TC99M, sesamib and tetrophosphine is bind to the mitochondrial, which is in the heart. Okay, our heart is a very active organ. It has abundance of mitochondria. So if the blood supply to the area is good, it will go more tetrophosphine and sesamib will go inside that muscles and is trapped into the mitochondria. Okay, that's how the principles. But if the blood vessels is not good, there is less sesamib goes to the area, so we can see that it reduces uptake there. So for image acquisition, we do ECG gating. It means that we synchronize the ECG and our image. So the principle of ECG gating is we use RR interval on ECG, because one RR is representing one cardiac cycle. Typically, we divide it into 8 frames. the RR interval is divided into 8 frames, but some recently they also divided into 16 frames. So each image will be each image will be stored in each frames. Then we will get multiple images lah of that frames. So we can get, because of the ECG gating, we can see the cardiac in motion. We can see the contractility of the cardiac. Secondly, after the scan, we can see the sinogram. The sinograms allow for the identification of patient movement in the horizontal axis. So this is how the sinogram looks like. Okay, and these panograms detect the movements of vertical axis. Quite a summary of how to do the TC99M system EB and tetrophosphine SPECT scan. I think for the physicists, they come to this area, SPECT reconstruction parameters. Our physicists actually helped us with this reconstruction parameters, especially which filter is the best for certain images and so on. Okay. For image processing, okay, when we do the cardiac scan, we process the image to become these three views. Okay, they are short axis view, horizontal long axis view, and vertical long axis view. So, okay, this is how it is done. For the short axis, we can see the image like a donut, like a small donut. So it's like the computer will slice the cardiac from the base of the heart to the apex. Okay, this is what we call apex of the heart. Then this is the base of the heart. So they slice it like this, so it will looks like a donut. Okay. For the vertical long axis, the computer cuts the heart from the septum to the lateral wall. Septum is located in the middle to the lateral wall. Okay, so this is how the image looks like. And the third one is a horizontal long axis, where they cut the image through the left ventricle from anterior to the inferior wall. So the image will looks like an N like this. So in summary, the physician will have to obviously look at these three views, axial, horizontal, and vertical axis. These are some of this is an image of what we normally look at in a patient for after the myocardial perfusion scan. We will arrange the image from the top will be axial slice, and vertical long axis and horizontal long axis accordingly. Stress on the top and the rest at the bottom, so that we can compare if there is any difference during stress and rest. So you may wonder why we want to slice all this the cardiac muscles into all these shapes. It is because it's easier for us to detect the location of the culprit lesion. Okay, we already have this diagram. Okay. So as you can see that this donut shape, we divide it into 4 segments, where this is a anterior wall, this is a lateral wall, inferior wall, and septum. So septum and anterior wall generally will be supplied by left anterior descending artery. Inferior wall generally will be supplied by the inferior artery, and lateral wall will be supplied by the left circumflex artery. So in this axis, we look at it differently, where we see this is apex. So and in apex, this one we can see apex, that's okay. But for the apex, we look at this view, and apex can be supplied by either LAD or RCA. And this is anterior wall. So we know anterior wall is supplied by LAD and inferior wall is supplied by RCA. Similarly, this view, the lateral wall is supplied by the lateral left left circumflex. Sorry, it's a move pula. Sorry. Sekejap, my computer macam hang.
Oh, your computer is hang. Okay, maybe Mbak Mira can share the presentation. I think you can share the PPT from your computer.
I'm sorry, Dr. Kidir, I don't have the presentation. Maybe.
Oh, who's have the file presentation?
Itulah komputer aku. Sekejap I will share again.
Okay.
Share screen.
And if participants have a question, please don't forget to read in the meeting chat. But if you willing to ask directly, you can ask after Dr. You can ask after Ibu Dr. Khadijah finish her presentation. Okay.
Can I just can I do like this? Maybe because we do the presenter view, the becomes weird.
Okay.
Can you see? Can you see?
Yeah,
Yes, we can see your screen.
All right. Okay. So after we see the image in that three different view, we also have what we call bullseye or polar map display. Polar map display, you just imagine as though as the heart is viewed from the apex and is open up like an umbrella. Okay. So the view will be like this. So in the middle is the apex. And it will be the lateral, septum, inferior, anterior accordingly, this one, and the different artery that supplies it. To make this more complicated, okay, we also divide the cardiac, the image that we have just now into 17 regions of the cardiac imaging, because we want to differentiate if the defect is in the apical segment, or in the mid segment, or at the basal segment. That is all the reason. So coronary arteries and supplies, I think all for the doctors, we need to know this, but maybe not so for the physicists. And artifacts. Okay. The artifacts comes in various ways. Artifact means the thing that can reduce or makes the image looks bad. So first, of course, from the patient problems. So for the patient problem, we can screen. The doctor can screen for the patient problem. If the patient has a left bundle branch block, or if the patient has balance ischemia. If the patient has a balance ischemia, means all the three vessels are equally stenosed. So as I said just now, our myocardial provisions can see look at the difference of the uptake of the blood supply or representative as the uptake of in the scan. But if it is balanced, means all three vessels may look the same, and we may think that this is normal, but it is not. Okay. As for the technologies problem, of course, injection, if the processing is not right, and what physicists always come is the equipment. So you can play with the attenuation correction, with the gating and all that. This is where the physicist comes in. So the common artifacts in our scan comes from breast, lateral chest wall, diaphragm, and abdominal visceral activity. All these will give different artifacts in different areas. So motion artifacts, as I said just now, a sinogram is the one that we use to visualize them if there is motion problems. Sometimes when the patient, we ask the patient not to move during scans, but sometimes patient cough. So when patient cough, there will be a misregistration of the image. So it will become like this. Okay, we can see that this is not the image is not very good because this is a page movements. So what we do is we will do the scan again. These are the corrected image. It looks okay. And if the patient have a left bundle branch block, we may look as if there is a reduced uptake in enteroceptor region. Enteroceptor is this one. But so we may diagnose the patient to have myocardial infarction. But actually the patient don't have myocardial infarction. Okay, for extra cardiac activity, like in this image, you can see that there is the image is not good because there are something down here. Okay, this is we have this problem many times because the bowel and the colon is very closely positioned near our heart. So when we have this kind of image, we will ask the patient to drink a lot of water to move the traces away, and we will scan the patient again. Okay, the diagnosis, how we do the diagnosis of the ischemia. When we compare the stress and rest images, and the only defect like this one is only seen at stress and a fully reversible at rest. This is what we call ischemia. So for example, this is a single vessel ischemia. We can see just one area in the inferior wall and lateral inferior wall that is they have no uptake here, and it's fully reversible at rest. So this is inferior right coronary artery problems, and in multi vessel disease, we can see more than one areas of defect during the stress and fully reversible at rest. Okay, actually this is how we look. This is the full view of what we view in our scan. We can see, we can have the data such as ejection fraction during stress and also ejection fraction during rest. So if you can see in this case, the ejection fraction during stress is 31%, and during rest is improved to 39%. So it shows that there is weakening of the left ventricle during stress because of the ischemia, myocardial ischemia. So we also have a non-reversible, or we call it fixed defect. Fixed defects during stress and rest indicate scarring or fibrosis, usually after myocardial infarction, or chronically ischemic, or we call it hibernating myocardium. So this is what we see if there is a stress defect, is a fixed defect. So the image during stress and rest is the same, like this one. So this is the anterior wall defect, similar stress and rest. And like this, okay. So recent advancement in myocardial perfusion scan is MPS is important to detect microvascular disease in coronary vascular in CVD after anatomical imaging failed to locate the artery stenosis. For example, there's patients who have already undergone coronary angiograms and CT, but they couldn't find the culprit. But the patient still complain of chest pain during running or something. So we can do myocardial perfusion scan. If there is any defect there in our scan, it means that this patient have microvascular disease, which means that the problems is in the capillaries, the small vessels. Okay, I will talk about cardiac amyloidosis. It causes restrictive cardiomyopathy by extracellular deposition of proteins in the myocardium. The protein has unstable structure that causes them to misfold, aggregate, and deposit as amyloid fibrils. There are two types of amyloidosis, light chain or transthyretin type, ATTR. So for the nuclear medicine, we want to diagnose the ATTR type because the cardiologist can give them some treatment for the ATTR type. Okay, what are the symptoms for cardiac amyloidosis? These are hypertension, hypertrophic cardiomyopathy, heart failure with preserved ejection fraction, and amyloidosis is also is a systemic disease. It's an infiltrate disease associated with non-cardiac soft tissue deposition. Patient may have carpal tunnel syndrome, lumbar spinal stenosis, bicep tendon rupture, and anatomic or sensory polyneuropathy. The treatment for ATTR. So they can give treatment. At the moment, they're using DMARDs like tafamidis and all of these to reduce the deposition of the amyloids. So what are the radiators used for the scan is very simple. We use TC99M pyrophosphate. Pyrophosphate previously is used for myocardial infarction imaging, and also previously they use it for bone scan, but now we have a better tracers for bone scan, which is MDP or HMDP. So for the image interpretation, there are three steps: visual interpretation, semi-quantitative, and heart to contralateral lung uptake ratio. As for the visual interpretation, we graded the scan for 4 grades, grade 0 until grade 3. So the baseline is grade 2. We compare the myocardial uptake if it is equal to RIP or not. So grade 3 is greater than the RIPs. Grade 1 is less than the reuptake, and grade 0 no uptake in the heart. So this is how it looks like. Okay, grade 0 there's no uptake in the heart. Grade 1, grade 2 is similar with the RIPs uptake, and the grade 3 is more than the RIPs. As for the quantitative, we do the some calculation here. We draw a circle in the heart and copy the circle and put it in the lungs, contralateral lungs. And the computer will give you the count and we have to calculate lah. Okay. So at 1 hour, if the score is 1.5 or more, we can say that it is ATTR positive. And at 3 hours, 1.3 is the number to say that this is ATTR positive. Okay, last but not least is iodine 123 or 131 MIBG scan. It is a scintigraphic assessment of sympathetic innervation of myocardium in patient with NYHA class 2 or class 3 heart failure and a left ventricular ejection fraction of less than 35%. There are many other indications for this scan, but basically we want to evaluate the sympathetic nerve systems in the cardiac, whether it is still okay or not. Okay. So because MIBG is noradrenaline analogs, so it will go inside the muscles. It will go inside the nerve. If the nerve is still okay, right? So there are a few ways to calculate it, but I don't think I want to say it here. This is how the normal iodine 123 MIBG scan look like. It shows that all the heart has a good nerve supply. And these are the examples of grade. As for this one, in A, reduced uptake in the heart, but the ratio is 1.7, it's normal. Sorry, this one is a good uptake. This B is a reduced uptake, and the C is poor uptake. So what is important? Why we want to do this scan is because one, it is related to the prognosis of the patient in heart failure. So if the patient has a very poor heart to medial standard uptake, the prognosis of that patient is not so good. It means that he might die anytime because of heart disease. Okay, if it is still good, then the doctor can possibly do some treatment for the patient, optimize the treatment. If the patient needs cardiac implantation ICD, they can do it. But if the patient has a poor uptake in the heart ratio in the heart, then there is no point of doing any more intervention, because the patient will die, basically die at any time, right? So thank you for listening. That's all from me. Sorry for the problems just now.
Okay, thank you for the very nice presentation. Okay, now we go to the discussion session. And I think we have a question from chat room. Okay, but I'm sorry, I don't know why my devices cannot display the meeting from participant. I can see a chat only from co-host. And I think we have a question from Bapak Adiwaseno. I think it's better, Bapak Adiwaseno, are you still here? I think you can ask directly to Ibu Dr. Khadijah.
Okay, Doctor, you have mentioned that you have a problem with some physiological motion or artifact from the other organ. So how we can make sure, differentiate that our image is okay, not annoyed by other artifact from organ or maybe from detector? How we can differentiate is it from the tool or from the patient?
Okay, we can look at the patient's body. Okay, if the patient has a big breast, we know that this might give artifacts. So we have our measures on. We can strap the breast. We have our measures lah, and the patient we can ask the patient to we can do the scan in a prone position. And for the if the patient is obese, patient gemuk, we expect that there will be a diaphragm attenuation in the inferior wall. We also look at where the wall, which wall is obstructed lah, macam tu. So at the moment, because we have a SPECT CT machine, we can do attenuation correction using CT scan, but we don't do it for every patient because of the radiation dose that involved. Does that answer your questions?
Hello.
Yeah, thank you, doctor.
All right.
Okay. Okay. And then we have Ibu Nada. She raised her hand, I think. Ibu Nada, are you here?
Banyak nasi. You, me.
Ibu Nada? I think Ibu Nada Sofia Amatullah. No, okay.
Yeah, okay, hello.
Okay, hello.
Mister, yeah.
Okay.
Yes. Okay, please speak. You can ask your question.
No, Mister, I don't wanna ask something.
Oh, okay. Okay.
Yeah.
Okay. I think we have another question from Bapak Arj Naufal. Okay, Bapak Arj Naufal, please, you can ask directly.
Okay, thank you. I have one question. So in case of the patient is moving during the examination, can we do something about motion deblurring instead of pre-scanning the patient? Thank you.
What is a motion deblurring?
Maybe it's some kind of a filter to smooth the image. In case of the motion. The patient motion. Yeah.
It depends. It depends on the how bad is the patient move. If the patient moves very little, we can use a certain filter or something. But most of the time, if the patients move too much, so the image will become very bad. So we have to rescan the patient. So now most SPECT machine is equipped with the motion, as you said, but it's not as good if the patient moves too much.
Okay, thank you.
All right.
Okay, I think the time is up. The time is up, but I think we should have another question, the last question from Bapak Panji. I think Bapak Panji, please.
Okay, terima kasih. Thank you very much, Dr. Peter. Dr. Khatijah, I have questions about your research. Have you conducted the research by using another modality, such as by using MRI, perhaps?
MRI is under the radiology department. So we nuclear medicine will not involve directly in the MRI imaging. We only do cardiac. We only do imaging using nuclear medicine scanner.
Okay, so but do you have any experience that the same research have been conducted in MRI modality in USM or in your center, perhaps?
I think Dr. Khairia might be able to answer that question.
Okay.
But she is the radiologist doing cardiac imaging.
Okay. Okay. Thank you very much, Dr.
All right.
Khadijah.
Okay.
Okay. Thank you, Ibu Dr. Khadijah. I think the time is up. And please give applause to Dr. Ibu Khadijah for the next presentation. Okay. Now we will go to the next presenter, Bapak Dr. Panji Triadyaksa. But before we give the time and screen to Bapak Dr. Panji Triadyaksa, I will read the short CV about Bapak Panji. Okay, Bapak Panji Triadyaksa finished his bachelor's in physics from Universitas Diponegoro, Indonesia, and continued his master and PhD in University of Groningen, the Netherlands. His research focused on quantitative imaging evaluation, especially in magnetic resonance imaging or MRI. Moreover, he also works on early disease identification by using MR and machine learning nowadays. Nowadays, he worked with Kyushu University, Japan, to evaluate the potential of quantitative T1, T2, and T2 star for early detection of microvascular obstruction. Moreover, together with his colleagues from informatics department, he also worked on disease identification using machine learning segmentation. Okay, that's the short CV of Dr. Panji Triadyaksa. And now, Dr. Panji Triadyaksa, the time and screen is yours.
Thank you very much, Dr. Peter. Let me try to share my screen. Oh, sorry, this one. So, okay, can you see my screen now?
Yes, we can.
Okay, hopefully I can remove this. Okay, can you see my screen? But
Yes,
is it also together with the Zoom video or not? Or only the PowerPoint screen?
Only the PowerPoint screen.
Okay, nice.
Okay.
Then I will skip first and then return to the first screen. Because in my screen I can see both the PowerPoint and also the Zoom screen together. And it will be a bit annoying. So it's only a full screen, right, Dr. Kider? Only the PowerPoint screen, right?
Only the PowerPoint screen.
Okay, thank you very much. Okay, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh. Thank you very much for attending this meeting about my cardiac research. At this occasion, my name is Panji Triadyaksa. I will present my project regarding the magnetic resonance evaluations on myocardial iron body. This presentation is what we said a short overview of several research that we have been conducted in several years in our research center in University of Groningen. We know that heart disease have several definitions. The first is described as blood vessel disease, such as coronary artery disease or cardiovascular disease due to atherosclerosis. But also heart disease can cause based on heart rhythm problems or arrhythmias. We also can have heart disease due to congenital heart defects or heart disease that we or the patient have from their inherited or since they're born. And also we can have heart disease due to the heart valve problems. Another is the disease from the heart muscle or myocardium. And the last is the cause of heart disease due to infections. My main research is with the heart disease due to heart muscle problems. So in general, for the disease of the heart problems is that the heart chamber become stretch or thickness or stiff. So we have 5 different groups primary of this kind of disease. The first is hypertrophic cardiomyopathy, dilated cardiomyopathy, restricted cardiomyopathy, arithmetic, and unclassified cardiomyopathy. And from this group, we will discuss about the iron-loading or the storage disease. The type of disease is what we say it comes from the hemochromatosis. Is defined as a disorder of the iron metabolism resulting in accumulations of iron in paraseminal tissue. In particular, the cardiac, liver, gonad, and other pancreatic tissue is involved in the hemochromatosis, and which the toxicity of redox active iron in that tissue is accumulated. And when it is accumulated, it can cause in organ dysfunctions. Thalassemia is also another type of disease. Is the iron-loading disease caused by inherited blood disorder, characterized by the decrease of hemoglobin productions. People with thalassemia, they mainly have inherited disease from their parents, can get an overload iron in their blood. This problem can happen due to of the disease itself or by the frequent blood transfusions.
Benda ni free,
Sorry for that. Therefore, too much irons in the blood or in the myocardium, especially in the muscle myocardium, can result to the damage of the heart. And also it can cause not only to the heart, but also to other organs like in the liver or in the endocrine system. Therefore, we want to know how can we predict the iron accumulations. One of the idea to predict iron accumulation is to quantify its progressions. The way we do that is by using magnetic resonance imaging or MRI. We can do MRI to evaluate the iron depositions accumulations by using the P2-star evaluations. So in doing P2-star evaluations, first we need to have a sequence for that. So in MRI, we use the multi-gradient echo sequence. And then by doing this P2-star evaluations, by using the sequence, in the end, we will have like a quantitative value of the P2-star. And we can highlight that if we have a P2-star value in the myocardium of above 20 milliseconds, then we can indicate that the patients have no high risk of heart failure. And however, if the patients have P2-star value between 10 until 20 milliseconds, that will indicate that the patient has increased high risk of heart failure. And more, in the worst scenario, if the P2-star value is below 10 milliseconds, that indicates that the patient has a severe or a high risk of heart failure. Therefore, we want to investigate how can we quantify this P2-star value by using multi-gradient echo images. So how can we do that? First, we have like we showed in the screen, we have like the multi-gradient echo image series. So we have image series from A into H. This series is differ on the echo time image. So the A is the early echo time image, mainly about 2 milliseconds, until the H is the last echo time image. In normal sequence, it will be like around 18 until 20 milliseconds. And then from there, what we can do is that we try to make a segmentation to define the myocardial area. By doing the segmentations, here we see that in image B, we draw the contour, the endocardial and epicardial contour. The endocardial is the red line and the epicardial is the blue line there. We evaluate that by manual drawing contour. So we can use a software that already provided by the vendor, the MR vendor or other third-party vendor. Or we can develop the software by ourselves by using several programs. For example, in my case, we use MATLAB programs to doing this. And then first we make the contour manually. And then after we draw the contour in one image, then we propagate the contour on several images, on all images, I mean. And after doing that, we try to acquire the signal intensity of all myocardial area, and then plot the signal intensity into the plot like this. So we use the x-axis of the echo time and the y-axis of the signal intensity. And after that, we perform the evaluation by using these equations. And by doing these equations, then we can get the T2 star value. So this is what we say the manual evaluation. So we do it manually by manual drawing of the myocardial contour. But the problem arises by doing this is that each echo time image has its own unique contrast information. So you can see from image A until H, the shape of myocardium is different. That's due to the effect of the image worsening when we increase the echo time. That we can say it happens due to the decrease of signal because of the free induction decay in the MR theory. This can induce different preference of using echo time image. So different preference can happen. So for example, in the previous case, I choose image B to draw the first contour, but other observer or other researchers can perhaps use image A or image C. Therefore, no standard reference image can be used to draw the myocardial contour. This is, for example, if another researcher using image A and other researcher using image B, then the possible contour difference can happen. And then what is the problem by doing this is that when the contour is different, then the signal intensity evaluations of the overall myocardial area also can be different. Therefore, our idea is to improve the inter-observer reproducibility in drawing the contour by assessing the standard contrast to noise optimized composite image. So we try to use one composite image to draw the contour, rather than using selections of one of the multi-gradient image as a template. So we try to evaluate two different methods: visual selected image method, and also another method we call the composite image evaluations. So this is the method. This is the scheme that we did. So first we draw the one template to draw specific regions in the myocardium and the surrounding area. And then we check the contrast to noise ratio of that surrounding area. The yellow ROI is the lung, the blue ROI is the right ventricle blood pool, and the red ROI is the left ventricle blood pool. And then we try to combine these three values from the surrounding area to generate evaluations to get the composite image that has the highest contrast to noise ratio. So we combine the three images that has the higher contrast to noise ratio between the myocardium and its surrounding. And then by using this composite image, we can draw the contour on that image, and then that contour will be propagated to all multi-gradient echo images. And from there, we evaluate the T2 star. We have published these evaluations in our previous article, and the results shows that by using the contrast optimized composite image, the data analysis improved So it's improved the reproducibility of myocardial contour detections. And then it leads also the consistency of the Titu star evaluations. And from there, we go further to, we already solved the image selections. Now we want to know how can we do the contour drawing, not only manually, but also automatically. So we take the next step. We try to evaluate how can we use this contrast enhanced image as a baseline to make an automatic segmentation. So we use this composite image and then get the value. And then we use those templates as a template to draw the automatic myocardial segmentation. So the idea is like this. So first we have the image, and then we just make a round circle in the myocardium, and the output is that we can have the endocardial and epicardial contour. By doing this, then we can evaluate the Titu star value. As simple as that. But the reality in the technique is not as simple as that. It costs. It consists of several steps. The first step is we need to draw the ROI at the center of myocardium. And then because we use the bright blood image, the image intensity is not that good to differentiate between the myocardium and surrounding. So we try to make the image into a dark blood image. By doing this, then we can have like the image number B. And in image B and also in image C, what we did is that we make the K-mean clustering. The idea is to get the blood pool area. So we make evaluations until D, E, and then F and G to get the contour evaluations by using the active contour segmentations to get the blood pool area. So at image G, we have the blood pool contour area. And then from there, I'm sorry for that. And after we get the blood pool and the blood pool contour, we use that as a template to expand the possible myocardial area. That's what we did from image H until image L, HIJKL. So what we did that we create the radial segment, and then we evaluate the signal intensity and K-mean clustering per segments and apply some contour correction on that image. And the end is that we have image M, the myocardial contour, but we still did a small refining process to get the correct contour, which is image N. So that's the final idea or the final process. By doing that, we saw that, well, in this case, we have 4 observers drawing manually and also 4 observers perform the automatic evaluations. And then what we got, is that we have similarity in the contour reproducibility between observer and within observer doing the performance in 4 times. So the evaluations improve the contour drawing. We can see the p-value is significantly different between the manual and semi-automatic, and this is the 0.85, 0.8, 0.74 is the dissimilarity coefficient value, the evaluations value that we use to evaluate contour relations. And by doing this, we get the improvement of the Titu star evaluations. We published this in 2017, mentioning that the applications of this technique improve the reproducibility of the Titu star quantification. So in this step, we already improved the image selections, and also we can improve the automatic segmentations of the myocardium to evaluate the Titu star quantifications. But the problem still arises here. In the bright blood multigradient echo image, the image itself is prone to artifacts, especially at the longer echo time. So we can see in image A, B, and C at the latter echo time at the right corner. You see that the image is become blurred compared to the early echo time. Therefore, we might suggest that we don't use all 8 echo time images to evaluate the T2 star. Some researchers get an idea that, oh, okay, maybe we can use a constant value or offsets constant to evaluate the T2 star. And other researchers suggest that, oh, maybe we don't use the later echo time. We can use only the first 4, 5, or 7 echo time images to evaluate the T2 star. We said that the SNR truncation or the R-square truncation methods. This is the idea of the truncation method. The SNR truncation method explained below is that if in figure 1, we eliminate the letter point, signal intensity point, represented by the letter echo time images, and to get the fitting that fits the models in order to acquire a high R-square value. That's the SNR. The idea is that first we evaluate the image contrast to noise ratio or signal intensity, and then after we evaluate the signal intensity, signal to noise ratio of each image, and then we sorry for that again. And then after we evaluate the signal intensity, signal to noise ratio, when the signal to noise ratio is below our threshold, then we exclude those images, especially at the latter image. Then we only use images, echo time images that has a high signal intensity or signal to noise ratio. That's the signal to noise ratio truncation method. And the R-square truncation methods use the R-square value. So for example, if first we have all 8 echo time images, we evaluate the model, and then we get the R-square of that model. When the R-square model of the model is below our threshold, for example, we set threshold to be 0.99. Then when the threshold, the R-square is below our threshold, in this example is 0.92, then we try to eliminate later echo time to able to get the model close to our threshold. In our case, perhaps 0.99. So that's the idea. We first eliminate 1 point, check the R-square. Is it close or above our threshold or not? If it's not, then we continue eliminating points. And usually by using this, many observers or many researchers will end into 3 points, which is not good. However, that's the model. And then the problem arises at least until before we publish the article, is that no direct comparison was made to evaluate the difference between the 2 methods. And therefore, we try to compare the 2 truncation methods to see whether the methods give a different iron depositions evaluations or not, especially at the 3 different coronary arteries. And then this is our results. We show that by using the mono-exponential method in the second column, that is the standard methods. And then we try to evaluate the SNR method and also the R-square method. The main result is like this. When the patient is severe, especially in the T2 star below 10 milliseconds at the lower images series, there were no difference between the 2 methods with the normal mono-exponential method. However, when the evaluations take place for the early detections, especially people with perhaps like in the beginning of having iron loading, in the moderate iron loading or no iron loading, but have an indications of that, then the 2 methods give different results. That gives a further investigation. So which method can give a good results? Because we can see the T2 star value is differ between the 2 methods in this case. And then if we check the evaluations into T2 star map, we can see also various different T2 star regions in the T2 star map. This is the example of the evaluations on this image and these regions. And then if we check the R square is the fitting, the goodness of fitting of the evaluations. We see that when the value is red, it means that the evaluation per pixels in this case is good. But when the evaluation is close to blue, then the R square fitting is poor. And it happens mainly when we have artifact or susceptibility artifact at the inferiolateral area. That can happen especially when we use the R square truncation method. We have published this in our article in 2022 about the T2 star assessment in 3 coronary arteries by using differential exponential truncation method. And it shows that, well, as I already explained before, that the method can have good evaluations and also can be used interchangeability when we classify the severe conditions. However, in moderate or in the moderate or in normal conditions, we have the different results. Therefore, we need to do further investigations to evaluate this, because we need a gold standard T2 star value or gold standard iron loading value, iron loading conditions to evaluate whether which method can really identify those iron loading locations. And another result from the T2 star in our research is that we found 3 different coronary arteries T2 star value in different coronary arteries territory. Here is the coronary artery territory. We know that we have 3 left anterior descendant, right coronary artery, and left circumflex coronary artery. And then those coronary artery give blood supply to the myocardium and also can influence the iron loading on that specific area of myocardium. And we see that here the evaluations of by using 3 different models state that the T2 star at different coronary artery are different. And also this is the evaluations not only on different coronary artery region, but also at the 16 AHA segments or American Heart Association segment, the 16 segments model. This is interesting. I mean, the result is interesting for further investigations whether this indication, whether this indication is correct or not by using the T2 star or iron loading gold standard. In the end, I want to emphasize that we already have a review article about the cardiac T2 star mapping by using different technique and different approach. If I able to highlight, we show that we not only use bright blood model or bright blood sequence to evaluate the T2 star, but we can also use the black blood model, the black blood sequence model. The model gives a different presentations of the myocardium and its surrounding. It's better to use the black blood model instead of the bright blood, but not many centers use the black blood. So the bright blood model is still common, especially in the old centers. And we also emphasize that when we use the bright blood models, it can induced by several artifacts. In this case, the phase encoded artifacts or motion artifact in the phase encoded directions that can influence the T2 star evaluations. This is also another opportunity to identify the process of artifacts and also to correct those artifacts, because the artifacts influence the signal intensity value. And then in the end, this is the last screen. We also highlight that if we use a different scanner, so if we use 1.5 and 3 Tesla scanners, we can have different iron loading stratification. So the T2 star value can be different So we cannot use the T2 star value, the stratification value, the value below 10, between 10 until 20 and above 20 milliseconds to the T2 star evaluations at the 3 Tesla, because at 3 Tesla, the T2 star value is different. So I think that is the end of my presentations, and I welcome for any questions or discussions. Thank you very much.
Okay, thank you, Pak Panji, for the very good presentation. Is there any question from participants?
Is my voice heard clearly?
Okay, yes.
Okay.
Please ask the question.
Thank you for your awesome presentation, Dr. Panji. I want to ask for the bright model. What is the drawback or for using it, since you say that it's preferred to use the black model rather than bright model?
You mean the bright blot or the black blot models, you mean?
Yes.
Okay, so I will go to this slide. Yeah. So the question is whether are there any drawback by using the black blot, is it, or the bright blot?
For using bright blot, so is it increase noise or the influence the segmentation?
Yeah. Okay. So the challenge by using the bright blot model is higher rather than using the black blot models, because at the bright blot models we also facing the problem with the signal intensity difference and the image quality difference between the myocardium and its surrounding. You can see here at the right, at the left image series number A there, at the 2.59 milliseconds, there are no difference between the myocardium and the blood pool. However, in the black blot models, blood pool series, I mean, there are fixed differences between the myocardium and the blood pool, not only at the early echo time, but also until the later echo time. So it's easier to do the image selections, or also the automatic quantifications or automatic segmentations in the black blot compared to the bright blot. So based on our experience, I mean, and also other researchers' suggestions, it's best if we now focusing the black blot model or black blot sequence to evaluate the T2 star. However, even though by using the black blot sequence, the artifact is also occurs, because we have several data sets from QSU in the black blot sequence. We also found that what we say previously, the motion artifacts at the phase encoded direction, it's happened. So we need to also encounter this problem, and it's not easy, but it's possible. However, it takes a focus research on that, and I welcome if you interest in this particular topics, and also other topics. I mentioned. No problem with that. Thank you.
Okay. Is it possible for me to ask one more again?
Yes, no problem.
Okay, for the using for this study, is it the scanning using the contrast or not, or if the contrast influence the segmentation results for this study?
You mean the contrast agent?
Yes, of course.
No, we don't use contrast agents for this study.
Okay, thank you, Mr.
Okay, you're welcome.
Okay, there is one question from a meeting chat from Bapak Adiwasono.
Yeah.
Okay. Let's try to read. I have a question, Mr. Panji. I'm still confused what quantification in your presentation. Is it different with like quantification of left ventricle ejection rate? that usually we use in clinical application.
Okay, yeah. Well, I can say that it's a different quantifications because for the ejection rate, we quantify the ejection fraction percent value by using, well, in the technique, we use the cine imaging, I guess, for the quantifications of the ejection fractions. And then from that cine imaging, we evaluate the end-diastolic and end-systolic myocardial volume. And from there, we make an evaluations to acquire the ejection fractions. In this case, we use the multi-gradient echo image series to evaluate the quantitative of to quantify the T2 star value. So yeah, from my experience, we can get one image, T1 image, T1 weighted image, T2 weighted image. And then we can also have, like in this case, the T2 value or the T2 star value or T1 value, but not from one image, but from several images or image series. And then we try to check the signal intensity at the specific locations on that series, and then put it in an equations, the T1, T2, or T2 star equations. In this case, we use T2 star equations. And from there, we can acquire the T2 star quantitative value. That quantitative value is the value that we use to identify a specific disease. In this case, we identify the iron loading disease. And I hope that my answer can satisfy your questions, Dr. Adi.
Thank you, Mr. Banji.
Okay, you're welcome.
Okay, we have another question from Bapak Hausam Mansur. Despite the success of threshold T2 star technique, myocardial T2 star measurement are subject to artifacts generated from myocardial motion, and those from float, such as ghosting artifact and partial volume effect. Oh, so what's this question? Bapak Hausam Mansur, or maybe Bapak Khairul Anam? Okay. Waalaikumsalam warahmatullahi wabarakatuh.
Yeah, Doctor, that maybe that cardiac T2 star may be facing to caustic artifact and partial volume. Maybe that affect the accuracy of the cardiac T star, and if we can use another modalities to correlate it to increase the efficiency of cardiac MRI.
Yeah, I agree with you that the problem is not only with the artifacts due to the motion heart motions, but also due to the image quality, because the image quality from the scanning itself is not that good. It has low resolutions, I can say. Therefore, we also facing the partial volume effect in the evaluations. Yeah, I also agree that we need to compare the T2 star value with other modality or other gold standard methods to evaluate the iron depositions. But based on our experience, the gold standard is not easy, because the normal gold standard for the iron loading identification is by using biopsy, which is we try to inserting needle into the heart and then get some part of the muscle of the heart and then check in the laboratory whether we have iron or not. And in biopsy, it's not containing the whole information of the heart. And normally what they did is that we try to extract the heart from the lab body and from the cadaver, and then try to evaluate per slice of that heart to evaluate the T2 star evaluations to see the similarity results. Yeah, but yeah, I welcome if there are any new modality that can be used, for example, the T1 evaluations or other, maybe the nuclear medicines evaluations to evaluate this the iron loading problems. That's also interesting. to see whether the identifications by using MR can also be identified by other modality, or for example, by using CT, or by using the nuclear medicines, or by using the gold standard methods. Thank you.
Yeah, Doctor, can I please that maybe that the cardiac systolic dysfunction may be presented also if the teeth start normal? Can some literature reported that may be presented the systolic dysfunction even that teeth start normal? Can we that accurate this result and maybe that use the echocardiogram to that correlate this result or not?
Yeah, I mean, using echocardiac evaluation is also interesting, because the idea is like this: even though the T2 star value mentioned that the patient has a normal, moderate, or severe iron loading indications based on the T2 star value, we're still unsure about the level, because the progression, the iron loading progressions is vary between patients, and it's also increasing with time. So to validate the method needs another modality or another quantifications evaluations. And for that, we haven't conducted any comparisons methods, but in the future we welcome if other, or perhaps you want to collaborate with us to investigate further with other modalities for this specific study.
Yeah, thank you very much, Doctor.
Okay, thank you.
Okay, is there any maybe last question from participant? No. Okay. If there's no more question, let's give applause to Bapak Dr. Panji Triadiaksa.
Okay, thank you very much.
Okay, thank you. Okay, for a very nice presentation. Okay, now let's go to the next speaker, Dr. Nur Khairiah Karim. Let me read first about the CV of Dr. Nur Karim. Okay, Dr. Nur Khairiah Karim received her bachelor degree in medicine and surgery in 2003 and Master of Radiology in 2014 from University of Malaya, Malaysia. She then obtained her fellowship in cardiac imaging from the National Heart Center, Singapore in 2017. She has received international clinical recognition. Sorry, I have a problem with my... Okay, she has received international clinical recognition in cardiac imaging, including level 3 certification from both Society of Cardiovascular Computer Tomography and Society for Cardiovascular Magnetic Resonance, and currently a fellow of the society. At the national level, she is the co-opt council member, special interest group in cardiac imaging, College of Radiology, Academy of Medicine of Malaysia. She is currently a senior medical lecturer of Department of Biomedical Imaging, IBPT, and consultant radiologist at Pusat Perubatan USM Pertam. At the administrative level, she is the Deputy Director of Clinical Services, Sustainability, and Standard of IBPT. Her current research areas include medical image processing and analysis with special interest in cardiac and breast imaging. Okay, that's the brief CV of Ibu Dr. Nur Khairiah. Now let's give the screen and time for Dr. Nur Khairiah. Okay, Dr. Nur Khairiah, the time is yours now.
Yeah, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Very good afternoon. I think it's almost afternoon to everyone there in Indonesia and also from Malaysia. Is my voice clear for everyone to listen to?
Yes, it's clear.
All right. Okay. So my name is Khairiah. I'm a radiologist from Advanced Medical and Dental Institute, and also working under USM Medical Center in Pertam. Okay, I'm actually subspecialized in cardiac imaging from Singapore. Okay, and currently holding the administrative position as Deputy Director as well in clinical services. So thank you, Mr. Chairman. I'm very proud today to be able to give my speech or my lecture on the role of cardiac computed tomography and cardiovascular magnetic resonance imaging in diagnosing cardiovascular diseases, a brief overview of what we are able to do on our side as radiologists to diagnose these patients. Okay, so basically for my lecture today, I will talk more towards the diagnosis of the role of modalities in diagnosing all these diseases. So before I move on, I would like to welcome all staff, all the lecturers, all staff from University Diponegoro in Semarang, Indonesia, to our Advanced Medical and Dental Institute, and also to our USM Medical Center. Okay. And the objective of my presentation today would be the approach of patients with underlying coronary artery disease, the indication for cardiac computed tomography, and also looking at calcium scoring and coronary artery angiography, and also a brief indication for cardiovascular magnetic resonance imaging from the perspective of radiologists. Okay. As what we mentioned by Dr. Khatijah and also from Dr. Panji just now, so we know that ischemic heart diseases or cardiovascular diseases are the main causes of death in globally and also in Malaysia. So in 2021, we have come up with 2020 statistic whereby the highest number of death is caused by ischemic heart diseases. Okay, and followed by pneumonia and also cerebrovascular diseases. Okay, and we are seeing the same pattern in both male and also in females. Okay, the number of patients that's presented with death is about 17% for ischemic heart diseases. So an overall overview of cardiovascular diseases worldwide, there is about 17.9 million people that's dying from cardiovascular diseases, and estimated of 31% of all death worldwide. Okay? And more than 75% of these deaths occur in those countries that is low to middle income countries. Okay, that would include in Malaysia as well. Okay, and 85% of all cardiovascular disease death due to heart attacks and also in stroke. This is subsequent to mostly from atherosclerosis. So we need to look at the pathology of atherosclerosis. Okay, we know that we have the vessels, the coronary arteries. Okay, we have three main coronary arteries that I will actually present later to show everyone a clearer picture. Okay, but what happened in our vessel? Okay, you can see from the left to the right. Normally our vessel is normal, but when lipid accumulate, okay, you can see that the cholesterol actually accumulate at the wall of the coronary arteries, okay, and it can have internal rupture as well. Okay, thereby it will actually progress into calcified shell and calcified plaque. When we have this calcification, then only we are able to detect it using our imaging modalities. Subsequently, this calcified plaque can actually be vulnerable. So we have this vulnerable plaque, and it can actually complicate by rupture and also thrombus and stenosis the coronary arteries, causing myocardial infarction in patients. Okay. So again, at the early stage of these pathologic changes, you can see that most of the patients come to us being asymptomatic. So we might be healthy, we might not have any chest pain, but deep down inside us, the heart, the coronary arteries, we can have calcifications, and this can actually be detected by certain modalities such as cardiac CT. Okay, so when we have this calcified plaque or this vulnerable plaque ruptured and thrombosed and block the coronary arteries, then only the patients will develop the symptoms of having chest pain, nausea, vomiting, sweating, and what we call as heart attack, and it can actually complicate by death. Again, patient may be asymptomatic and look happy, but when the patient come to us being symptomatic, they will be very in pain, and we need a quick management of this patient. Okay, so we as the doctors, okay, as the primary physician, especially those seeing patients in the clinic, we have to intervene early. So in patients with heart diseases, especially in those with ischemic heart diseases, it is important for us to actually prevent them from the early stage. Okay, so what we do is primary prevention such as lifestyle modification. Okay, kita boleh suruh pesakit, okay, jangan makan benda berlemak, okay, benda berminyak. And also secondary prevention when we have to do certain procedures such as invasive coronary angiography and continuous to take medications for the patients. So how do we actually stratify this patient that is coming to us with coronary heart disease or coronary artery disease? So in 2008, okay, Ralph Agostino and et al. Had actually published the general cardiovascular risk profile for use in our primary care, or what we call is the Framingham Heart Study that is well known worldwide. Okay, it was published in 2008. The study is actually looking at 8,000 plus patients with the mean age of 49 years old. The age range is between 30 to 74 years old, okay, and looking at their risk as well as the cardiovascular disease events. So what are the events that they are looking at? It would be coronary artery disease, heart failure, okay, cerebrovascular accident, and peripheral arterial disease. So they actually follow up this patient for 12 years, okay, looking at whether the patient has any cardiovascular disease or events, okay. And after 12 years of observation, about 1,000 plus patients actually had a single event of cardiovascular disease. So this is considered very significant findings based on the Framingham Heart Study, whereby it is very important for us to actually re-stratify this patient that actually come to us, okay? Especially those with comorbidities such as diabetes, hypertension, dyslipidemia. So when we as doctors at the primary centers at the clinics, we would like to actually re-stratify this patient, and there are various calculators available online that we can actually stratify this patient accordingly, okay. The most important thing is looking at the age, the gender of the patients, whether they have any comorbidities as what I have mentioned earlier, dyslipidemia, diabetes, hypertension, whether the patient is smoking, whether they are consuming alcohol, and whether they have any other diseases such as coronary artery diseases, peripheral vascular diseases, and also stroke. Okay. So what I'm showing here is one of the calculator that you can actually find online. Okay, the Framingham Risk Score calculator that is based on the 2008 article that is being published. Okay, you can see here that in this patient that they're showing as an example. Okay, with all the information being keyed in, you can see that the 10-year global CVD risk for this patient is more than 30%. Considered high risk, and the vascular age is approximately estimate of more than 80 years of age. Okay? So when we do this is very important for us to actually re-stratify and make sure that the patients being given the appropriate treatment. Okay, another risk calculator that we are looking is the atherosclerosis CVD risk calculator that is being published by American College of Cardiology. So what we do is we key in everything. We key in the blood pressure of the patient. We key in all the levels of cholesterol and whether the patient has any underlying comorbidities, and we will get the risk of getting cardiovascular events in 10 years time. So again, just to simplify in a slide, okay, you can see that if our risk is less than 10%, we are considered as low risk. If the risk is approximately around 10 to 20%, we are considered as having intermediate risk of getting CVD event. And if it is more than 20%, we are in the category of high risk. Again, as what I have mentioned earlier, what we can do at our site as images, we can actually look at the progression of atherosclerosis via certain modalities, okay, and the focus would be on cardiac computed tomography. So when the patient has calcified plaque, we can actually detect it by using this modality. Okay, I'm showing here what we are looking at in the short axis, okay, or the transverse axis of a coronary artery. You can see that in healthy patient, when we do calcium scoring using CT, we are usually this calcium score is 0 and we will not see any calcification. Okay, but please note that if we have these early changes of atherosclerosis, whereby there's presence of fatty streak along the lumen of the coronary arteries, as well as atheroma, okay, without the presence of calcification, okay, or what we call as soft plaques, okay, soft plaques. So the coronary artery calcium scoring would also shown as 0 as well, okay. So CT, we are able to look at calcification, but if the patient has soft plaque, it will not actually identify this as calcium. Okay. So the next would be within the atheroma phase and fibroatheroma, okay, while the vulnerable plaque is with those with fibrous cap and lipid core, okay. This is what we call as mixed plaque. So mixed plaque is when we have calcified plaque plus a non-calcified or soft plaque, okay. And if the patient has this mixed plaque, the calcium score is usually around, it will be more than 0, but usually less than 100, okay. All right, what about those with calcified, very hard collagen calcified plaque? We will actually detect it as coronary artery calcium of more than 100, and this will be shown in our CT scan. So please note that although we have this mixed plaque and we have calcified plaque, together they will actually increase cardiac mortality in patients. So what does calcium score means? Okay, when we have a high score, okay, more than 100, okay, it can be hundreds, okay. High score indicate high burden atherosclerotic plaque, okay, and it is a very specific marker for atherosclerosis. It actually does not occur in normal arteries or other pathological condition, okay. However, it does not reflect the severity of luminal stenosis. Okay, remember that when I said that if the patient has soft plaque or mixed plaque, it can actually does not represent a true calcification, and soft plaque can actually cause luminal stenosis. So it doesn't actually reflect by this calcium scoring. Okay, and it better predicts the value and has been shown to positively impact the patient compliance, especially to medication, okay, and also lifestyle modification. Okay. And it is important in planning primary prevention interventions such as giving statins and aspirin to patients. Okay. In this table, we are looking at the calcium score And you can see here that if the calcium score is 0, we will classify the patient is having very low risk. Okay, 0 to 100, low risk. 100 to 400 will be intermediate risk. 400 to 1000 will be high risk, and more than 1000 will be very high risk. So it depends on the calcium score that we are getting by CT scan. So we have various recommendations such as lifestyle modification, or whether we need to intervene by giving the patient treatment such as statins and aspirin, and whether the patient is suitable to do functional tests such as cardiac scintigraphy or myocardial perfusion scan as mentioned by Dr. Khatijah previously. Okay, so this is another brief infographic showing the 10-year risk categories for atherosclerosis cardiovascular disease, looking at low, borderline, intermediate, and high risk, whereby it is important again for us to actually emphasize to patient that it's important to have this lifestyle modification, okay, whatever the risks are, and when if the patient has borderline risk, we will need to actually look borderline to intermediate. We will need to look at the coronary artery calcium scoring and see whether there's any risk, other risk factor, and whether we need to start statins or not. Okay. So indication and main role of coronary artery calcium scoring is first, asymptomatic patients with intermediate risk. Okay, the intermediate risk, as what I have mentioned earlier, is absolute 10-year cardiovascular disease risk of 10 to 20%, do not have any underlying coronary artery disease, and the age is between 40 to 75 years old, where it has the ability to reclassify patients into lower or higher risk groups. Okay. It will actually guide the treatment goal and empower your patients to actually comply to cardiovascular risk reduction intervention. Okay, so we can actually emphasize on lifestyle modification and also pharmacological treatment such as given statin and aspirin. Okay, so when we should not perform coronary artery calcium score, when the patient has a very low risk, that is less than 5% absolute 10-year risk when we are keying using the calculator, okay, or a very high risk, more than 20% absolute 10-year risk, as testing unlikely to alter the recommended management. So what I have mentioned earlier, for those with high risk, usually we will intervene by doing invasive coronary angiography and given optimal medical therapy. Okay, for symptomatic or previously documented coronary artery disease, there is more established predictor to actually further risk stratify this patient using echocardiography, using exercise stress tests, and looking at the biomarkers such as troponin level. So coronary artery calcium score has the role as a gatekeeper. So if calcium score is more than 400, you may actually want to reconsider doing CT coronary angiography, as running the risk of non-anesthetic coronaries can actually cause blooming artifact in this patient. So this is the anatomy that we are looking at when we actually perform CT coronary angiography. Okay. Number 5 is, so we have few vessels that are very important when we actually report, okay, to look at the stenosis level of each of the vessels. The main one would be our left main, number 5 here that you can see, okay, followed by our left anterior descending artery, okay, that goes in between the anterior interventricular septum, okay, which has the branches of diagonal 1 and diagonal 2. The next main one would be our circumflex, okay, that goes to the left atrioventricular septum to the back, okay, that give branch of obtuse marginal 1 and obtuse marginal 2, and to the back where it gives rise to left posterolateral branch or left posterior descending artery. So we have now the left main, we have LAD and the LCX. the circumflex artery. The last one, the number 3, the third main artery would be our right coronary artery, okay, that usually give rise to the right posterior descending artery that goes to the inferior interventricular septum, okay, at the back, and usually give rise to the right posterolateral branch as well. Okay. What I'm showing here are the anatomy images of coronary arteries that usually can see when we are performing CT coronary angiography. So again, looking at all the main vessels that I have actually mentioned earlier, okay, focusing mostly on the left main, the LAD with its branches, the LCX, okay, the RCA, and also the PTA that goes to the inferior interventricular septum. So you can see here that by doing coronary angiography, CT coronary angiography, you can have a better evaluation of the coronary arteries and evaluation of the stenosis within it. So in IPPT or in PPSMB, in my institution, we are also performing this in patients that are coming to us with intermediate risk. Okay. As what you can see here, we are able, using the appropriate software, we are able to look at the vessels, okay? We look through, along the vessels and see whether there's any presence of stenosis. And this is a VRT or volume rendering technique looking at the 3D image of the heart, okay? So I'm sure at your center, yeah? Correct me if I'm wrong, Dr. Panji, at your center there in University Diponegoro, you are also actively doing all the CT and also MRI cardiac. So this is what we are doing when we actually performing calcium scoring in patients using CT scan. You can see that the calcium within the vessels, the coronary arteries, will be picked up by the software, and we can actually have the capability to actually put in colors so that it will be more easier for us to interpret. So like in this patient, you can see that the yellow coronary artery represents the calcium in the left main and also in the left anterior descending. So once we have actually gotten all this calcium being detected by the software, it will come out automatically in the software with the appropriate scoring for this patient. Okay, next, we are looking at the indication for CT coronary artery angiography. As you all know, the sensitivity and the specificity of coronary artery angiography in detecting stenosis is very high. It ranges from 85 to almost 100% in detecting the stenosis. So this is the main modality that we use to actually assess. This is considered non-invasive. And this is normally used to assess whether there's any stenosis within the coronary artery of patients coming with chest pain. Okay. So when do we actually perform this? When the patients are symptomatic, okay, the low to intermediate pretest probability of coronary artery disease, you can have a negative predictive value up to 100%, and it can actually avoid going for invasive coronary angiography for this patient. And for those patients that are asymptomatic, the application of CT coronary angiography for risk assessment is not justified. Okay, so for those that are asymptomatic, normally we will actually risk stratify them and see whether they need to perform CT coronary angiography. Okay. Because of the high sensitivity of this modality, it can actually lead to more downstream investigation for this patient. Okay. So next would be those within the range of low to intermediate cardiovascular risk, such as young patients that come to us with chest pain. Okay. When we have anxious patient with symptoms, okay, symptoms such as chest pain, nausea, vomiting, sweating, okay, patient with atypical symptoms, and also when there are unclear ECG and also exercise stress test findings. Other clinical indications of CT coronary angiography include when we want to actually rule out coronary artery disease in acute chest pain, okay, using CT as alternative whereby we are unable to perform invasive coronary angiography because of the patient having high risk, okay, verifying unclear findings after invasive angiography, and also to assess coronary artery stents. So we have looked at the usage of CT in assessing the calcium scoring. Okay, the next would be looking at the vessels for stenosis. Okay, the next would be to assess bypass graft. Okay, bypass graft have larger caliber and less motion as compared to our native artery. Okay, and it lead to better image quality. So native coronary arteries, when the patient come to us, will usually have very severe atherosclerosis, very pronounced calcification, and usually frequently because of the blockage, it will have a smaller caliber, which makes their evaluation very challenging. So, but in our case, usually we will report the bypass graft as well as the native coronary arteries. And it is quite difficult for us to actually use the earlier generation of CT scans with limited number of slices, because the sensitivity and specificity is of only 86 and 76% to detect, to assess bypass graft. The next role of CT coronary angiography is to look at coronary anomalies. What are anomalies? That are abnormalities that it can be either congenital or it can be either, but usually it's congenital. Okay, it can be either due to complications, whereby some of the normal anomalies that we look at is usually the high takeoff of coronary arteries, the multiple ostia, meaning that the patient has more than one left main artery. When we have patients with single coronary artery that coming to us with chest pain, okay, and usually we will assess the origin of coronary arteries. And sometimes the patient can have anomalous origin of the coronary artery from the pulmonary artery, or what we call as lengkap. Besides looking at the origin of the coronary arteries that can actually cause chest pain in patients, we should also look at the cause of each coronary arteries. Okay, the cause would include having myocardial bridging, meaning that the artery actually go into the myocardium, course through the myocardium, traverse in, and cause. And when the heart actually pump, it can actually cause stenosis of the coronary arteries. Okay, so this can cause chest pain in patients, especially in the younger patients that coming to us with chest pain. Okay, coronary hypoplasia, meaning that the coronary arteries are not well formed. Okay, duplication of arteries. And sometimes we can have anomalies of the termination of the arteries, such as coronary artery fistula and also extracardiac termination. Okay, next, I would like to briefly describe the plaque that we are looking at using CT coronary angiography, looking at the characterization, whether it's calcified, non-calcified, or whether it's mixed, okay, having this calcified and non-calcified plaque, whether there's presence of dissection, ulceration, and also fissuring, okay? And we need to look at the location of each stenosis, which coronary artery is being involved, whether it's particularly related to the ostium branches and the bifurcation. So for radiologists, we have the radiology, the American College of Radiology has actually come up with a newer reporting what we call as CAT-RADS, okay, coronary artery disease reporting, okay, categories, where we will actually score this patient accordingly, score 0, 1, 2, 3, 4A, 4B, and 5, and compare it with the stenosis of, represented by stenosis of each of the coronary artery. Okay. As what you can see here, if the patient has no stenosis, no presence of stenosis, the score would be 0. If there's a minimal stenosis, we will classify it as having score 1, CAT-RADS 1, mild stenosis 25 to 49%, we'll score it as 2, more than 50%, score 3, more than 70% to almost 100%, we'll score it as 4A or 4B. And if total block, total obstruction, we will consider that as score 5 for this patient. So based on the scoring, we will actually have to further investigate the patient or do appropriate management for this patient. So this is another infographic that is looking at the CAT-RADS and also the level of stenosis in patients. Okay, you can see the classification whereby for CAT-RADS 3, if it's more than 50% or moderate stenosis, we will need to actually intervene by performing other imaging modalities such as functional assessment, such as myocardial perfusion scan, or even go and perform invasive coronary angiography for this patient. So it is very important for us to carefully evaluate each of the coronary arteries to look at the presence of stenosis and classify it accordingly. Okay. So this is an example of patient that actually come with minimal stenosis. You can see that there's presence of calcium. However, it does not actually cause significant stenosis in this patient. So the stenosis is less than 25%. You can see that with presence of calcium, it can cause blooming artifact in this patient. The next would be the mild. Mild is when we classify the stenosis as 25 to less than 50%. Okay. If the patient has a moderate stenosis, it will be more than 50% of the obstruction or the stenosis of the vessels of the coronary artery. So this is very important for us to intervene, okay, for those with moderate stenosis. And last but not least, the one that is having severe or almost total occlusion of the coronary arteries, whereby the severity of the stenosis is more than 70% to 200%. So we have looked at assessing the arteries, we have looked at assessing the calcium, look at assessing the bypass graft. What about assessing the stents? So you know that when we have patients coming with chest pain, when we perform invasive coronary angiography for this patient, it can be diagnostic or therapeutic. When we need to actually intervene, when we have moderate stenosis in patients having symptoms, then there's indication for stent to be administered to this patient. So stents are usually hyperopic, and it will be something like calcium-like, okay? Extensive concentric calcium and stent material will lead to variable ability to see inside the stent because it can actually cause blooming artifact. But it has great negative predictive value of more than 95%, especially for us to assess the instant restenosis or ISR, if we can actually clearly identify the lumen of the stent. Okay. However, the positive predictive value is quite poor. It's around 50%. So again, the positive predictive value depends on the stent size. If we have a more bigger stent, then it'll be easier for us to actually evaluate the lumen of the vessel. So the sensitivity, the positive predictive value will be around 99%. However, as the stent is smaller in size, okay, the positive predictive value will be more reduced as compared to the, a bigger stent. This is an example of stents in stent that is being administered in this patient. Okay, you can see that it is causing blooming artifact, and it'll be quite challenging for us to actually evaluate whether there's any presence of restenosis in this patient, although with the presence of having this stent. Okay, so enough about CT coronary angiography. I hope everyone has been able to actually obtain some knowledge on what we can actually do using CT coronary angiography. Okay, the next I will go briefly on the indication for performing cardiac magnetic resonance imaging. Okay, so a total different machine altogether. Okay, you know that CT coronary angiography, it is using X-ray to produce images. We will have radiation exposure to patients, but with cardiac magnetic resonance imaging it does not cause it does not allow radiation to be given to the patients, and it can actually aid in the treatment of patients in the following indications. Okay, so what we can see here, you can actually have the ability to actually assess the presence of myocardial viability, whether there's any perfusion defect. Okay, viability. Okay, so we know that in CT coronary angiography, we are only assessing the coronary arteries, but CT is not a good modality to assess the myocardium. So Dr. Panji has mentioned earlier that the indication of performing MR would be also include in assessing the myocardium or the heart wall. Okay, so this is very important for us to look at whether the heart tissue is viable or not. Okay, other indication would be cardiac masses and presence of thrombus. Okay, pericardial abnormalities, cardiomyopathy. Okay, if you have patients coming with poor ejection fraction. Okay, cardiac and liver iron overload, especially in thalassemia patients. Okay, congenital cardiac diseases, whereby we can look at whether the patient has any valve abnormalities such as regurg and also stenosis, arrhythmia. Okay, in patients, especially when we are looking at the atrium, okay, and also aortic disease. So this is what I'm showing here is an example of patients, okay, having a cardiac mass, okay, at the left atrium. Normally, when we are performing, I will not go into detail on the technical basics of performing cardiac MR, but you can see here that there are certain sequence or planes that we need to acquire before we are able to actually report or assess the cardiac MR. Okay, so just remember these four sequence or the planes that we need to look at. Okay, the four chamber, the first image on the left, upper left would be the four chamber. Why we call it four chamber? Because we are looking at both ventricles, the right and the left, and also both atria, the right and the left. So it's four chamber view. Okay, the one on the upper right side would be the two chamber view. We are looking at the left atrium and also the left ventricle. The next would be the three chamber view. Okay, we are looking at the left atria, left ventricle, and some aspect of the right ventricle, and looking at the left ventricular outlet, okay, LVOT. The next important plane would be the short axis. Okay, just imagine our heart like an apple, okay, or a mango, whereby we actually cut it through. So what we are saying is the slice of the apple. So you can see here on the below right side, that is the left ventricle, the one that is in circle in shape. So that is your left ventricle myocardium. Okay, the one that is circle in shape, okay, with the black intensity. Okay, so that is the left ventricle. And you can see here that the right ventricle is not round as what we are seeing of the left ventricle. So it's about the shape of a crescent shape. So you can just imagine that our heart is actually not really that rounded, but it's actually have this shape that we need to actually evaluate it using the short axis plane.
Excuse me, Ibu Khairia.
Yeah.
Actually, your time is up. So,
Yeah.
but please finish it maybe 2 or 3
Yeah.
minutes again.
Yeah, I'm finishing actually.
Okay.
So this is the 17 AHA segment that we are looking at. So the main one would be looking at the basal. Okay, 17 because we have 17 segments. Okay, we are looking at the basal segment, the mid myocardium, and also the apical myocardium, and also the apical cap. So this is when we are actually evaluating the short axis or the short plane. And for those patients with coronary artery diseases, we should actually assess the viability or the transmurality of the infarct or the late gait enhancement or hyperenhancement. So again, we are classifying it about 25% age. Okay, so 1 to 25%, we are considered it as a preserved viability up to 50%. If it's more than 51%, then we would consider that as non-viable, and we need to intervene by putting stents or etc. for these patients. And with late gait enhancement, you can see that we can actually classify the disease of the patient, whether it's in the ischemic group or non-ischemic group. As you can see, ischemic group mostly affect the subendocardial and transmural. And in non-ischemic, such as cardiomyopathy, usually it will affect the mid myocardium, the epicardium, and also the endocardium, the inner aspect of the wall, and also the outer aspect of the wall. So again, it depends on the hyperenhancement of the patients. So what you are looking here is the hyperenhancement or late gait enhancement that we can actually look only via MRI, because we are able to give contrast and see the presence of contrast within the myocardium. So this is the beauty of performing cardiac MRI in patients, so that we are able to evaluate the myocardium. So this is my last slide. The take-home message from my lecture today is it is important for us to do calcium score for those patients asymptomatic with intermediate cardiovascular risk, with the aim for us to actually guide the intervention or the treatment for the patient. Okay, for CT coronary angiography, symptomatic patients with low to intermediate risk, principally to actually rule out coronary artery disease because it has good negative predictive value. It is important for us to actually perform CT coronary angiography to analyze coronary artery disease because it has the capability to do several reconstructions such as maximum intensity projection, okay, volume rendering, okay, multiplanar information. And we can actually compare it phase by phase during systole and during diastole. And if you are not sure, again, as the primary physician and the ones doing the imaging, please do consult cardiologists if we are unsure of the diagnosis. So in our center, in our practice, it's normally good to have co-reporting by radiologists and also by cardiologists. So thank you. So this is my last slide. Thank you again to the organizing committee for inviting me to give this talk on the role of CT cardiac and also MRI cardiac. Before I end, I would like to wish everyone selamat berpuasa, selamat berbuka, and salam Aidilfitri minal wal faizin. And I hope everyone will have a good time with the family during this festive. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Okay, thank you for a very good presentation. Now we go to the discussion session. Maybe one question, I think from Bapak Husain Mansur. Hello, Husain Mansur. I think he want to ask something, or if there is. Okay, okay, maybe Bapak Panji Tiadiaksa, if you have a question.
Okay, thank you very much, Dr. Kibir. Dr. Khaira, good morning. Assalamualaikum.
Waalaikumsalam warahmatullahi wabarakatuh.
Yes, I saw in your presentations that you, I mean, if I'm not mistaken, that you evaluate the calcium scoring using the single via Siemens program. Is that correct?
Yes, correct. Yeah,
I mean,
single via Siemens. We have that dual energy machine in our center.
Okay, yeah, nice. Yeah, I also have that experience, but not in Indonesia, but with my study in Indonesia. My question is that is there any possibility to do the evaluations not only by using the single via, but also by using other programs or other dedicated programs, perhaps? Is there any research being conducted to that specific topic?
Yep, I think, okay, there are various machines that we know are capable of doing CT. In other centers, they are using GE, they are using Canon machine, Toshiba, in fact, okay, and they have various applications in order to analyze the coronary arteries, either in calcium score and also the coronary artery analysis, okay. And besides that, we also in our institution, we are using CVI 42. Okay, our CVI 42 is also capable of assessing our CT cardiac and also our MRI cardiac. So besides having all this, besides using single via, we are able to actually analyze using other applications, not limited to single via only, but it depends again to other centers that are using your own analysis software. Okay. But I think each machine, they will have validation already for each analysis that you're using, right, Dr. Panji?
Yeah.
They will have validation for each analysis, including calcium score.
Yeah.
So again, depends on each machine that you're using at your own center.
Oh, nice. Yeah, because well, in Indonesia, we are also interested to do the evaluations by building our own program.
Okay, good.
We are interested to develop the program by using Python or by using MATLAB.
Python, MATLAB.
Yeah, because the main point of the calcium scoring is also clearly understood, and then we can also develop the programs to do the image selections or the calcium detections, because we are familiar with the machine learning process for that. So I think it's also possible to evaluate that. But what we don't have is what you said previously, the validations, because we don't have the commercial software, the commercial software that we can use to compare our results to the dedicated software. Maybe if you are welcome in the future, perhaps we want to make evaluations based on our our calculations to your software or your programs.
Sure. We are happy to collaborate. We are. Thank you, Dr. Panji. We are happy to actually collaborate in any modalities that you want.
Because we're also interested with the LGE detections, because normally until now the detection is still visual analysis, I presume, and then it's interesting to also do, I mean, to also identify the LGE detections by using machine learning. We have conducted the analysis in tumor, and it's giving a good results on that, and it's more challenging to identify the LGE identifications. It's also interesting because the region is so small, but the intensity is quite high. Therefore, it's interesting to identify that small locations. It's also interesting to do that.
So it's very interesting actually. It will actually help us radiologists to better evaluate the patients, the presence of LGE, especially in quantification, in quantifying the LGE, okay, whether it's minimal, mild, moderate, or severe. So if we can look at the possibility of having this automatic segmentation of LGE, that would be great. And we can actually practice that in our center.
Yes, we already have several data set for that. The impact, I mean, to identify impact by using LGE. Yeah, we already have several data sets for that by from the queue. So maybe after we optimize our project, then maybe we can share it with you. Maybe you want to use it for your own data sets perhaps in the future.
Yep, sure.
Okay, thank you very much, Dr. Khairul.
Thank you so much, Dr. Panji.
Okay, maybe one last question from Bapak Mansur. Bapak Mansur Huasem.
Okay, Assalamualaikum.
Okay, Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam.
Hi.
Hi,
So no, I have two questions regarding the calcium scoring in the coronary angiography. I think that calcium scoring may be facing some limitation regarding the operator dependent when measuring the calcium scoring. Also, not all patients under 100 score have not stenosis. It may be have stenosis. Also, not all patients over the 400 that maybe have severe stenosis. I think that maybe that regarding the operator dependent in measuring calcium scoring, also the location of the calcium, it may be eccentric or eccentric. I think regarding the coronary angiography, that maybe also have limitation regarding the patient preparation and heart rate may be increasing. But my main question regarding the stent, I think that there's several limitation in measuring the low sensitivity in stent measurement, stenosis or stenosis. But I think if we can measure the Hans feed unit pre and post the stent, can be help us to measure these the stenosis?
Yes, we can. But just remember that sometimes when the patient has any blockage, we can have collaterals to some. It may be coming from the distal part. The contrast may be actually supplying the distal part of the stenosis area. Okay. So yes, I agree that we can actually measure the contrast level pre and post stent. Okay, it would be better if we can actually assess the inner part, the lumen of the stents. But again, it depends on the size of the stent and also the capacity and capability of our machines to evaluate. Okay. More newer machines are able to really look nicely into the lumen of stents. Okay, but I do agree with you. But probably we also need to assess individually at the patients whether they have any presence of collaterals that is actually supplying the distal part of the stenosis again. But I do agree that that is one of the in the analysis that we can do, looking at the contrast pre and post stents, see whether there's the stents is actually viable. Yeah.
Yeah. Okay. Also, that maybe that the blooming artifact in stent, it may be just in the volume rendering. Which means the 3D. So that the multiplanar and maybe reconstruction may be useful in that diagnosis. But we can agree to that in case of stent, we must to direct the patient to coronary catheterization. Also, in case of calcium scoring, I think that the underestimation regarding to the age. Regarding the below that less than 40 years, I think that there is no any calcified in these visits. So I think also that calcium scoring is more accurate than stress ECG. That may be considered that consider the eligible factors may be affecting the patient. Thank you, Dr. Noor.
Thank you
for your Doctor. Thank you.
Yeah.
Okay. because the discussion time is up, let's give applause to Ibu Dr. Nur Khairia. Okay, thank you once again for Dr. Nur Khairia,
Thank you so much.
for the nice presentation. Okay,
Terima kasih semua. Terima kasih.
terima kasih.
Dr. Kidir, terima kasih
Yeah.
Dr. Panji, terima kasih semua.
Okay, I think before we ended the session, maybe I would like to hear from Prof. Jarwani to give a comment about cardiac imaging. Is Prof. Jarwani is still here? Professor Jarwani?
Yeah, I'm still here.
Okay.
Oh, thank you very much. So that's really nice, nice lecture. Yeah, from medical doctors. Yeah, so that's really for us. It's really wonderful. And I have told you that before this webinar, just a little talk that in Indonesia now it's just cardiac center. Yeah, cardiac center is more than 400 now. Yeah, so that means we have to give special attention for medical physicists in so your lectures is very wonderful. So and for the introduction, yeah, introduction for us, yeah, from medical doctor side, yeah. So I hope it will trigger for medical physicists, yeah, from medical physicists for research, just like calcium scoring, yeah, Akhetan calcium scoring. Actually, it's still for medical physicists, it's really a little bit we have an idea actually, because calcium scoring is the whole calcium, yeah, the whole calcium. But even though the calcium is so small, but accumulated in just one side, it will be very risk. Then you compare with calcium scoring, a high calcium scoring, but so separated in so many places. Yeah, so it will be really for physicists. We have to verify whether this scoring is really correlation with high risk. This is the general is yes, but maybe for special individual, maybe we have to be investigated. Yeah, so I think that's really challenging for medical physicists. Yeah, this one, and so many things about cardiac. Yeah. Cardiac artery disease that actually for medical physicists it's maybe will be a subspecialist afterwards, because it's really very what you special area. Yeah. In nuclear medicine, of course we have started here. But unfortunately, the nuclear medicine in Indonesia is still not so many centers here. Maybe in Indonesia, you can imagine we just have 16 cardiac nuclear medicine centers. And for the PET, it's now maybe 4 or 5, yeah. So for cardiac, maybe with PET and SPEC will be developed for research, innovation, yeah, innovation. So many, I think. So thank you very much. This is for a very good opportunity, and I'm also thank you for the collaboration between University Diponegoro and university. I hope not afterwards, not just live with University of Diponegoro, and maybe you can have with other universities also. Okay. Thank you.
Okay, thank you, Prof. Jalani, for the comment. Because Ibu Khairiah is our last presenter, so my duty as moderator also ended here. And I would like to say thank you for the committee for having me as moderator. And we hope that this webinar will broaden our knowledge and makes our relationship between Undip and USM is more solid. And before I give time and screen to Mbak Anjani as MC, I would like to give the certificate for our keynote speaker. Please, I will share the screen. Okay, can you see my screen? This is certificate for Dr. Khadija Abdul Hamid. And then this is a certificate of appreciation for Dr. Panji Triagiaksa.
Thank you very much.
Okay, and then the last one is a certificate for Dr. Nur Khairiah Karim.
Thank you so much.
Okay, thank you. And I would like to give the time and screen to Mbak Anjani. Please, Mbak Anjani.
Thank you, Dr. Kidir Maulana, as a moderator in our webinar. Really interesting topic, right? Okay. Ladies and gentlemen, we are reached the end of the agenda. The last agenda is closing. Let us close this IPPT USM Undip joint webinar on multimodality cardiac imaging. We hope that all invited guests and participants are enjoying this event till the end and take the benefit. I am Mira Anjani, as the Master of Ceremony, would like to thank the 205 audience for the participation. Also, thank you for Prof. Widowati, Professor Maja Dr. Hasni, also Professor Heri Sutanto, Professor Jarwani, and also another professor come and attend here this event. We also apologize if there are words or action that are less pleasing. That's all from us. Let's close with Hamdalah together. Alhamdulillah. Happy fasting. Mohon maaf lahir dan batin. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you very much.
Terima kasih semua. Thank you very much.
See you again. Bye-bye.
Yeah.